Good evening. I'm Ashley Reef. I'm the nurse coordinator for the Adult Congenital Heart Program here at Houston Methodist. And we're very happy to have you here for DEBAKEY CV Live. We have a really exciting program for you tonight. We'll be discussing COVID-19 and adult congenital heart disease. With me tonight, I have a very special guest, Dr. Peter Hotez. Dr. Hotez is the Dean of the National School of Tropical Medicine and Professor in the Department of Pediatrics, Molecular Virology, and Microbiology at Baylor University, and co-director of the Texas Children's Hospital Center for Vaccine Development. Really great having you here, Dr. Hotez.
Thanks so much, Ashley, for having me.
And later in the hour, we'll hear a firsthand story of a congenital patient who was hospitalized earlier this year with COVID. We want everyone watching to have the opportunity to participate and ask us questions. We'll answer them as we move through our discussion. To send questions, please text DEBAKEY to 37607. That's DEBAKEY to 37607, and we'll try to get to your questions. So to start off tonight, I really wanted to ask you, Dr. Hotez, talk to us about how the COVID pandemic has kind of changed from the beginning in 2020 to now that we're about halfway through 2021.
Well, you know, Texas has been hit pretty hard, of course, with COVID-19. We've lost the lives of 53,000 Texans, which is an extraordinary number. It's arguably the worst single tragedy to ever affect our state. I mean, we lost around 20,000 Texans who sacrificed their lives for the country in World War II. So we're looking at something on that magnitude. So it is really devastating, particularly among certain populations. The Hispanic communities have gotten hit really hard in Texas. I testified to the Congressional Hispanic Caucus and been working with our Texas delegation, like people like Congresswoman Sylvia Garcia and others, and so that's been really heartbreaking. And especially with Black and Brown communities, the lives lost have been generally to much younger age groups. So the narrative out there is that COVID-19 exclusively affects older Americans, older Texans. It's not true. We're seeing a lot of younger moms and dads lose their lives, so it's orphaned a whole generation of Texans, and that's heartbreaking. Also, the fact that now with these new variants, which I'm sure we'll get into, we're starting to see more healthy young adults get sick and go to the hospital as well, and adolescents, and maybe it'll be kids as well. So I am very concerned about the impact, and I think the other piece to this is the narrative that's out there is we're out of this, we're done. And we're not, particularly here in the South. When last summer at this time, we started to see this slow uptick in the number of cases, and by middle of July, August, we were the worst affected part of the country, and I'm worried that's going to happen again, in part because we're doing such a terrible job vaccinating populations in the South that are vaccinated about 1/2 the level of the North. So whereas we're looking at 70%, 75% of the New England, Mid-Atlantic states have received a single dose of vaccine in Texas, and in many parts of Texas and in the southern states like Louisiana and Mississippi, Alabama, it's half that. So we have an incredible vulnerability, and I'm worried about a pretty devastating surge this summer.
Do you feel like maybe socioeconomic status plays into that when you're talking, especially about minorities? Because I know in Texas, it seems to be some of those border communities that are close to the Mexican border that tend to have some lower rates of vaccination, correct?
Well, actually, that's gotten better. So back around December last year, you know, a number of us have identified two major vaccine hesitant groups. One were Black and Brown communities that had high rates of vaccine hesitancy or refusal, and the other was conservative groups, depending on which survey you were looking at. So, which you wouldn't think ordinarily would have that much in common,
right.
but that was the case. Now, the vaccine hesitancy and refusal has come way down in Black and Brown communities. There's still a piece of it there, but it's nothing like it was. So the most vaccine hesitant groups are the conservative groups, and this coming out of a lot of misinformation being pushed out of that side, and so that's really where we have to start. Why the level of vaccination rates are so low in the South. It's primarily for that reason, and that's what we have to work on.
Okay, and I know, most of the people watching this are congenital patients or members of the general public. With the general population, we've kind of covered on television kind of the things that put those people most at risk and kind of the outcomes that come from those. Now, what about for the cardiac population? Or do you see things that put that population more at risk?
Yeah, absolutely. I mean, we learned pretty early on that among the risk factors for severe COVID-19 being hospitalized beyond age was underlying cardiovascular disease, hypertension, diabetes. So those were big risk factors. And on top of that, we have this increasing recognition that COVID-19 causes a lot of cardiovascular illness. So the original, when we were first hearing about COVID-19 emerging out of China and then into Europe, everybody thought it was going to be like the original SARS back in 2002, 2003. So COVID-19 is caused by the SARS-2 coronavirus. And the original SARS was primarily a respiratory pathogen and required people to be ventilated and causing acute respiratory distress syndrome. This coronavirus, though, is different. It's causing a lot of damage to the heart, damage to the vasculature. It's causing stroke and blood clots to form, thrombotic events. So it's much more of a cardiovascular disease than just about anything else, cardiovascular and neurologic. So individuals with underlying heart disease are at particular risk, and those are the ones that we probably have to vaccinate more than anybody.
Okay. And what about the cardiac population? Do you see them having more after effects, or do you have them seeing a longer duration of effects following COVID?
Well, what we're seeing is that people who do get COVID-19, even healthy young adults, are getting what are called long-haul symptoms or long-haul COVID, and those are having long-term heart issues and palpitations and shortness of breath, and also neurologic issues as well. They're getting what people are somewhat calling brain fog. They just feel that things are not quite right, and even depression and psychiatric symptoms as well. So I would imagine those with underlying cardiovascular disease, all that's going to be revved up. On top of that, the virus can cause inflammation of the heart, myocarditis, and so we're seeing a fair bit of that, especially in younger age groups. So if I know you're very interested in those with underlying cardiovascular disease and congenital heart disease, I don't know that the population is big enough to have been extensively studied yet, but all signs point to the fact that, yeah, they should be at pretty high risk. So that's why I'm here with you tonight, is because I want to work with you to get these groups vaccinated and try to overcome any vaccine hesitancy that they might have.
And really, I mean, you're exactly correct. There are only 2 or 3 studies that are really out there that have been done on COVID and ACHD in particular, and the largest that I could really find was about 1,000 patients, and they really found the same risk factors for poor outcomes, death, or long-term intubation in an ICU as are really found in the general population.
Yeah,
so
I think the issue is going to be if they have less cardiac reserve to begin with,
right,
then they're starting out with at least one, maybe not 2 strikes against them, but
right,
1 strike, right? So,
right, exactly.
So.
And it seemed to be those patients that already had pulmonary hypertension or a cyanotic heart disease that, they were, like you said,
right,
already starting kind of behind the 8 ball.
I think the message, though, that people need to hear is that this is overwhelmingly a cardiovascular and thrombotic disease. So that if you do have underlying issues around that, that's all the more reason to get vaccinated.
Mm-hmm. And, now that we're kind of moving into this new normal, should we be taking more or different precautions with our congenital patients compared to just any other person kind of entering into this, starting to leave home and things of that nature?
Well, certainly there was a big worry before we had the vaccine about the importance of non-pharmaceutical interventions, mm-hmm, social distancing and masks, and it was especially important to protect those populations from getting infected with the virus. Now that we have the vaccine, it's all hands on deck and making certain everyone gets fully vaccinated. And I can't emphasize enough the importance of getting fully vaccinated. By that I mean both doses of either the Pfizer-BioNTech vaccine or the Moderna vaccine. And the reason for that is because now we're starting to see new variants emerge, and particularly here in Texas. And a lot of that work has been done at the Houston Methodist Research Institute by Jim Musser and his group, and they've done fantastic work really showing us the spectrum of how these variants are emerging. And they just published an important new paper in medRxiv. I keep telling Jim I want to start charging him to be his publicist here. So, they've done some great work that just got published in medRxiv that shows now that not only is the B117 variant from the United Kingdom here in a big way, maybe 3/4 of the virus isolates, but now we've got the Brazil variant here, and very concerning, now we've got the Indian variants starting to come up. And this includes what some are calling the Delta variant, affectionately known as B1617.2, which is very memorable. And that one really worries me, because the B117 variant that came out of the UK, that we said, oh my God, it's much more transmissible than the original lineage. This one from India is even more transmissible than the B117, and we're starting to see now this is becoming the dominant variant in the UK.
Okay.
And now it's gained a foothold in the United States and here in Texas. And so the prediction will be, because what seems to be what's happening in England is going on in the United States, this one's going to become a new dominant variant, and it's going to be more transmissible than anything we've ever seen. So what does that mean? Well, first of all, it means I think we're going to start seeing more young people get infected than we've seen before. And they may have more serious illness as well. So this sort of ups the pressure to vaccinate anyone who's eligible to get a vaccine. And what I often say is, even if you're young and fit and healthy and going to the gym every day, that's not a substitute for having virus neutralizing antibodies in your system. The only way you can get that is through vaccination, and that's what you need to do, and the adolescents as well. But the other new information is that Delta variant, if you've only gotten a single dose of vaccine, it's not very protective.
Okay.
As opposed to some of the other variants. So the only ones who are really protected against that Delta variant that's now here and getting a sense is get both doses of vaccine.
Okay.
And it's going to take a week or two after you get that second dose before you have the levels of virus neutralizing antibody that you need. So why am I telling you this? So if I'm saying that we're going to have now this Delta variant from India here in a big way in Houston over the summer, and we're likely to see another big surge in Texas, in the southern part of the United States, this coming July and August, just like we did last July and August when it was so devastating. Don't decide to get vaccinated then. Right? Now's the time you want to get vaccinated, because, remember, let's say you take the Pfizer vaccine, single dose, you get boosted 3 weeks later. It's going to take another 2 weeks after that before you're fully immunized. And if Moderna, it's another week on top of that. You're talking 5. So even if you decide, okay, tomorrow I'm getting vaccinated, it's 5 to 6 weeks before you're fully immunized. And you don't want to do this in the middle of a surge. You want to do it now before that surge. So this is your window. If you haven't been vaccinated yet, this is your window period to get vaccinated.
I also get a lot of questions from people who have, our patients who have been vaccinated, and, they were working at home. We'd written them, letters to their employer, they need to work at home because of their cardiovascular disease, and now they're being asked to go back to work. So are these patients that we should continue to kind of push to have them remain at home, or does it depend on the work environment, or are people really vaccinated?
I don't think so, unless you're known to be severely immunocompromised, meaning a renal transplant patient that's gotten big gun immunosuppressive therapies, or if you're a CAR T transplant, recent bone marrow transplant, if you've been in those categories where you're on active immunosuppressive therapy, yes, you want to have a conversation with your specialty physician about that, but probably that's not the case in most of your adult congenital heart disease patients. So, this is something you definitely want to talk about with your cardiologist, but I would think those individuals, can resume a full and normal life after they've gotten their two doses of vaccine. Now, there may be an need to get a third immunization later on in the year in order to be more resilient against the variants. So that's already being discussed. So if you've gotten 2 doses of the Pfizer Moderna vaccine, you may need a third dose later on this year or the beginning of next year, and we're waiting for that guidance from the CDC. And whether that'll be the same vaccine or tailored more around the variants, we'll see. But so that's probably the only, have some situational awareness around that. But I think otherwise they should be able to resume their previous activities.
Okay, so it looks like we have a question. When do you think we ACHD patients should be looking for a booster shot? Should we take more caution as we get closer to that date? For example, a mask, stay at home, etc.
Yeah, the 2 doses should give you pretty robust immunity. So no, I don't think so. So unless there's some specific guidance. And the other piece to this is each medical specialty has their own association, their own professional association of physicians. Mm-hmm. And this is the kind of thing where I would hope that the American Heart Association, for instance, would come out with specific guidance around that. So, and maybe there's something out there. I haven't checked the AHA website recently, but unless there's some specific guidance otherwise, or if you hear from your cardiologist, I think it should be okay to resume your normal activities now if you're fully vaccinated. But again, Ixnay on the single dose of the Pfizer or Moderna, that doesn't count. You want to get both doses, be fully vaccinated.
Some of our patients I know have asked, which vaccine should I get? Which one would we recommend? We usually say you just need to get vaccinated.
You just need to get vaccinated. I think the level of protective immunity from Pfizer and Moderna is slightly higher than the J&J. There is this rare cerebral thrombotic event that's been noted in with the J&J vaccine. It's extremely rare. I mean, the likelihood of you getting it is about the likelihood of being struck by lightning. But I don't know if there's any, literally. I mean, I actually have I go up a lot against the anti-vaccine groups and wrote a book called Vaccines Did Not Cause Rachel's Autism, because I have a adult daughter with autism and intellectual disabilities. And I actually looked it up. The odds of being struck by lightning are 1 in 750,000, according to the National Geographic, in your lifetime. Who knew, right? And they're about similar numbers for that cerebral thrombotic event. So it's extremely rare. But you might want to have a conversation with your cardiologist also about it. I'm a little reluctant to get too far ahead of my skis of patients who are under the care of a specialty physician, because they may have some more specific information specifically tailored to their underlying condition. So that's why it's especially important to have that conversation. But as far as I know, all of the 3 vaccines that are available should be okay.
Okay. And then we also have patients whose, they've been vaccinated, their spouse has been vaccinated. They can get maybe one of their 2 children vaccinated because the other is too young. So I've had parents ask me, do I have to do something different? Do I have to do something different for my little one? And then when do we think we're going to see CDC approval of, FDA approval of the vaccine for younger?
So right now the vaccines have been released for emergency use in anyone up to 12 and up. And we expect full approval to be forthcoming, and we can even talk about the differences between full approval and emergency use authorization. They're actually not nearly as big as some people claim. They're pretty close because the FDA worked hard to approximate the full approval process for emergency use. But with regards to the younger kids, I don't think we're going to have that safety and efficacy data for the little kids under the age of 12, at least for a few months. Some say as early as the fall. I'm a little less optimistic, but so you're right. So if you are in a family with kids of different ages, chances are, and if you can have, both parents vaccinated and your adolescent kids vaccinated, but you'll have little kids who are not vaccinated. So then the answer is, so what does that mean? Well, I think, as we head further into the summer, assuming that there's widespread vaccination in the community, the level of transmission is really going to drop. Unfortunately, that's more likely to happen in the Northeast than in the South because we have so much vaccine resistance in the South. So that's the kind of thing you want to keep in mind. So what I've been saying, so if you were living in Massachusetts or Connecticut or New Hampshire, Vermont, I would say within a few weeks, people should feel comfortable going around without masks, and life should look just like it did pre-pandemic. In the South, we'll have to see if we're going to see that uptick because of the poor vaccination rates. So that's the only caveat I would say. So right now it's looking pretty good, but we're still watching and waiting. So therefore, for now, I would say if you're with little kids who can't be vaccinated, when you're bringing them into stores or restaurants, you want to have them have a mask still.
Okay. And then I've had a few patients ask about, they're vaccinated, their spouse is vaccinated, but of course they're a congenital patient. So they've been, of course, kind of programmed from a young age that, they have a chronic illness, they have to take extra care of themselves. And they've asked about, their spouse traveling for work or their spouse going to, say dinner meetings and being asked to dine without a mask or go into a restaurant without a mask. And should they kind of push back on that? And it is here, so of course, we're also talking about where, there is that vaccine hesitancy.
Yeah, and again, for everything I'm saying, the risk is never going to go to zero, at least for the next few months to a year or so, until we totally halt transmission. So I think that's something to keep in mind. What I would say is this. And let's take that scenario. So you're at home, you feel you're at higher risk than others, even though you're vaccinated, and your spouse going out for dinner, or going golfing, or that sort of stuff. If your spouse is vaccinated, the vaccine has a great performance feature, and that not only is it reducing symptomatic illness, but it's greatly reducing asymptomatic transmission, meaning it's reduced, even if that person gets the virus, they're not transmitting it, are greatly reduced because there's antibodies going into the nose and mouth and reducing virus shedding. So the risk is not zero, but greatly reduced. That's how strong the performance features are, at least of the Pfizer, BioNTech, and the Moderna vaccine.
Okay. And what if, I have other patients that say to me, they come in for an office visit, and of course we still require you to wear a mask when you come into the office, and they say, why do I have to wear a mask? I have my COVID vaccine. Or when we do pre-procedure COVID testing, they say, well, I'm vaccinated. So what's kind of the response to that?
Yeah, I think it's, eventually that will probably go away as well. So at Baylor College of Medicine, for instance, now when you go into the building, if you're vaccinated, there's a sign you don't have to wear a mask.
Okay.
But for instance, I went for a doctor's visit and I had to wear a mask. Mm-hmm. And I think it's because there are a number of immunocompromised patients in the building, and I think that's out of abundance of caution. But I think that may change as well if we can really lower transmission.
So what's the protection from just the vaccine versus having a mask and the vaccine? How much does the mask give you a lot more protection then?
Well, I can't give you a number. I mean, having the vaccine is the most potent thing you can do. Certainly wearing a mask will even help that even further. So
right.
If you think you're one of the problems is we haven't studied extensively this vaccine in every population in terms of whether they're especially people who are immunocompromised, around immunosuppressive therapy. So of the limited studies that were done, it looks as though a single dose of vaccine is not nearly as good as 2 doses, and 2 doses is pretty good, but it's still not perfect. So I would say if you are immunocompromised, again, have a conversation with on immunosuppressive therapy, have a conversation with your specialty physician, your hematologist, oncologist, your rheumatologist. Typically, those are the ones who wind up giving immunosuppressive therapy, and understand the parameters a bit better. But if it were me and immunocompromised and I had doubts about how good the vaccines are, I'd probably still continue to wear a mask.
Okay. Now, I'm cheating a little because I read Preventing the Next Pandemic, so I kind of know the answer to this question, but I want you to tell our patients. So for all of our patients that say, well, I don't want to get this vaccine that's this new technology, the mRNA, can you explain to them why we're not really talking about something that's as new as everybody?
Yeah, I mean, I would, one of the myths, or one of the, sort of the fake anti-vaccine talking points is that these vaccines were rushed and not adequately tested. And I point out, well, for instance, we've been working on coronavirus vaccines for 10 years, starting with SARS and then MERS. And that 10 years of work showing, that the spike protein is the soft underbelly of the virus, and how you deliver the spike protein, how you induce virus neutralizing antibodies, all of that went into this. So the idea that these vaccines sprang out of nowhere ignores the fact that these vaccines have gone through at least a 10-year research and development program, as well as the RNA technology. And unfortunately, what happened was a lot of some of the CEOs of the pharma companies, when they send out their press releases, they're not writing them for you or for me, they're writing them for their shareholders, and they tended to spectacularize their accomplishments. And I understand why they did it, but it has the unintended effect of getting people scared. And calling this thing Operation Warp Speed, that didn't help much either. And I don't know who thought of that, but it was just a terrible, terrible name. And because it gave the false impression that these were rushed, and also the fact that these were released through emergency use. In the beginning, even I was concerned about it, but as I spoke more to the FDA and saw what they were doing, those guys worked really hard to closely approximate the full approval process. The only difference between the approval process for full approval and emergency use, in the case of the vaccines anyway, was that for the emergency use authorization, they relied on 2 months of safety and efficacy data rather than the full year ordinarily required for approval. And they did that because at that time we were losing 3,000 Americans every day from COVID, and the loss of life would have just been too staggering. But even after emergency use, it's not like they said, okay, adios, we're done, right? What the FDA and CDC did is put in a very elaborate what's called pharmacovigilance process for safety and efficacy monitoring. So the long of it is the emergency use process is really not much different than the full approval process. So this idea that people aren't going to get vaccinated because they think it's experimental or it's not fully approved, it's a spurious argument. It's not the case at all. It's practically spot on, and now the formal approval should be pending as well. I mean, the companies have requested the formal approval process. So you should feel very comfortable taking a COVID-19 vaccine. It was the size of the phase 3 trials was as big as any other vaccine, and now this vaccine has been given to more than 100 million Americans, almost 200 million Americans, and lots of safety and efficacy data. And the proof of that is how robust that pharmacovigilance monitoring system is. They were able to pick up this rare event, this cerebral thrombotic event, in the adenovirus vaccines, the AstraZeneca and the J&J vaccines, which was as common as being struck by lightning. And yet they still could pick it up. And so I have enormous confidence in the process and what the FDA and CDC does, and people should as well.
So as part of that pharmacovigilance, is that, like, I got text messages after I got my vaccine, and every week I would get a text message saying, how, do you have these symptoms?
That's right. That's right. And there's actually 4 or 5 different parallel systems of monitoring. So everybody points to VAERS, the Vaccine Adverse Events Reporting System, which is passive, but there's Vaccine Safety Data Link. There's what you just described. So there's lots of belts and suspenders to monitor this.
Okay. And then kind of looking forward to the future. Now, we know that we continue to kind of have this vaccine hesitancy. We know that it's probably something that's going to persist because we know we've seen it with other vaccines. So do you see employers in the future kind of requiring their employees to have be vaccinated, or maybe airlines as we travel, or some other organizations like that?
Possibly. The Biden administration has said we're not going to do any government mandates. I think they just don't want to poke that bear. They've got enough other issues. But some employers will. And the places where I see vaccine mandates are going to be one for colleges and universities. So, for instance, my youngest son, who works in the oil and gas industry in town, he studied petroleum engineering engineering. When he went off to college, he had to show proof of his meningococcal vaccinations, meningococcal B and ACWY. Why? Because if you're in an institutional setting, that's a deadly disease that circulates very, very quickly. I would say that's going to be probably what you'll see on college and university campuses for COVID-19 vaccinations as well. So I think that's one place. And then I think the other is going to be healthcare institutions. I mean, if I'm a patient in the hospital, I want to know that the person taking care of me is not shedding coronavirus. Right, and I think that's very reasonable, and but we'll see how it all shakes out.
Okay, and what looking forward to not just within our borders as the U.S., but when we talk about vaccine diplomacy, is are we going to continue to kind of fight this battle as there are variants elsewhere and people are traveling?
As you know, we're accelerating a low-cost recombinant protein vaccine now being scaled up in India, and the Indian government has just announced they're going to advance purchase 300 million doses with our collaborators at Biological E in Hyderabad. So that's very exciting to make that contribution. The problem is, as good as the United States is doing overall, as is Israel and the Nordic countries and Western Europe and the UK, that's about it. I mean, for all practical purposes, the African continent is not being vaccinated, and Latin America is terribly underachieving, and that's why that epidemic is raging through Latin America, right? And the death toll in places like Peru and Colombia is just staggering as it is in India. So the message here is, because there's a lot of international business in Houston, that's going to be a problem. Take the oil and gas industry. The economy is going to start to rebound as people are flying domestically and people are driving cars and using fossil fuels. But then we're going to hit a snag. We're going to hit a plateau. Why? Because it's still going to be hard to do business with Africa. It's still going to be hard to do business with Latin America and the Middle East and parts of Southeast Asia. So we're going to get capped pretty early because of that, and that's going to be a problem as well. So I've been pushing the Biden administration pretty hard to offer a plan of what we're going to do to vaccinate the world, but it's daunting. It's 6 billion doses of vaccine in order to vaccinate fully the world's low and middle income countries in Africa, Asia, Latin America. We just there's no plan yet for that.
Right. So is there anything that we can do, as healthcare providers or even our patients to help get our country vaccinated and, kind of as a result, maybe help other countries as well?
Well, I think, the Biden administration has announced they're going to start donating doses. I want to see the Biden administration take a more active role in actually producing vaccine for the world, because even if they give out 500 million doses by next year, it's still tiny. It's less than 10% of what we need.
Right.
So just donating doses is not enough. We need to actually manufacture these vaccines at scale, maybe our vaccine. And I think in the meantime, I am really concerned about this part of the country. I think we're in for a bad ride this summer if this virus returns, and especially the Delta variant, given the fact that our vaccination rates are so low. Texas is a little better than Louisiana and Mississippi, but I don't know, maybe the eastern part of Texas might not be as good. So that's got to be a pretty push to really get everybody vaccinated.
And what do you think is the best way we can help with that?
I think programs like this do a lot of good. I think it's a matter of education, because the anti-vaccine, anti-science noise out there is pretty high volume right now, and nobody says it quietly. It's always with screams and capital letters and exclamation points, as you see on social media. And often aimed at me. That's right. And so it's very shrill, and remember, these anti-vaccine groups, these are not mom and pop organizations. These are not grassroots organizations. These are well-funded, well-organized groups. The Center for Countering Digital Hate, it's amazing we even have to have something called the Center for Countering Digital Hate, estimates that the 12 leading anti-vaccine organizations have 58 million followers.
Wow.
So, and on top of that, you've got now this widening anti-vaccine activities among conservative groups, and if you're watching Fox News at night, some of the anchors are giving pretty strong anti-vaccine messages. That concerns me, and because that's not complicated enough, now we have the Russian government piling in. So U.S. and British intelligence have documented that the Putin government has launched this whole program of what's called weaponized health communication to basically destabilize democracies with anti-vaccine messages, and unfortunately that's working as well. So and also he's also discrediting Western COVID vaccines in favor of his own COVID vaccine, Sputnik V. So it's a mess. I mean, so what was sort of a small movement that came out of Texas with the political action committee linked to the Republican Tea Party is now a full-on anti-vaccine, anti-science empire. With the U.S.-based, well-organized, well-funded groups. A lot of them are peddling fake nutritional supplements. They're peddling, if you go to the books on vaccinations on Amazon, they're almost all fake anti-vaccine books, COVID conspiracy books. So I think my new book is one of the highest ranked anti-vaccine pro-vaccine books out there on Amazon. I think it's ranked 17 because it's preceded by 17 fake anti-vaccine books. And so they're peddling fake books, peddling nutritional supplements, they're monetizing the internet. They're making money on this, and that's part of the problem.
And how can patients know whether they're looking at good information, good science information?
Yeah, and some of them, some of these organizations have names that sound like legitimate organizations, and they're not. And the other problem is there's not sort of one-stop shopping for you can get the best vaccine information. I mean, the Centers for Disease Control website, cdc.gov, it's got a lot of great information, but mining it is complicated. I mean, I know where to look because I have an MD and a PhD, but if you don't, it's not as easy. And then there's vaccines.gov, there's the Vaccine Education Center at Children's Hospital of Philadelphia, where you were before. Paul Offit runs a very good website there. There's FACCpedia, run by a pediatrician here in Texas that's got a lot of good information. There's Vaccinate Your Family, but it's not like there's one place to say, here's the place you need to go. It's so that's part of the issue as well.
Right, for sure. Well, I appreciate you bringing all this information to us. This was super helpful, and I think our patients will definitely find it helpful as well.
Yeah,
and it's nice to have a true expert in vaccines.
Well, thanks. And
they call me like I'm the expert, but
yeah. Well, I'm always happy to come back. I mean, because as you know, COVID is very fluid, and what I said 2 months ago can look very different from now, and so again, I would say to everyone, having situational awareness and keeping up with the situation is going to be really important as well.
Yeah. Well, thank you. I appreciate you being here.
Thanks for having me.
For
and
sure.
Thanks for all the great work at Houston Methodist and the hospital and the research institute's contribution to COVID. You've had a big footprint in COVID-19 this year,
and definitely thank you for all the work you've done.
Thank you.
I didn't even realize until I read your book how long your work spanned and all the things that you've done. So I really appreciate, we as a country should really appreciate you and all you've done for vaccine science.
I appreciate it. Thank you.
All right, so now we're going to talk to Deborah Bartels. She is actually a congenital heart patient, and she was hospitalized with COVID-19. Hi, Deborah. How are you?
Hi, I'm great. How are you?
I'm doing okay. Can you tell us a little bit about your congenital background? What's your congenital defect? We can start off with that.
Well, I was born with 8. So which one do you want to learn about first? No, I have a double inlet left ventricle. I have a transposition of the great arteries. And then I have a small right ventricle. And they have what they call ventricular inversion. So because my right was so underdeveloped, the left kind of had to take on, they flip-flopped. And so the right and the left work the wrong way. They're not supposed to work the way they are working, but somehow they did. And then I had a pinching, the narrowing, the coarctation of the aorta. And then I had holes in my heart, both in the atrial septal area and the ventricular septal. I think that about covers everything. So it's quite a lot going on. I think I looked up one time how often does even one of these occur, and they're very rare. So for me to get 8, I apparently hit the congenital heart defect lottery.
If you call it that, right?
I know like some of these they sound really big, but mostly what it was is that everything kind of just developed, either underdeveloped or it developed the wrong way.
Okay.
So that was, I hope that clarifies
Yeah,
it.
for sure. For sure. So how many surgeries have you had?
I've had 2. I've had
Okay.
2. And my first one was actually Valentine's Day, 1978. Very appropriate. And all they were able to do was, at that time, they were able to repair the little pinch on the aorta
Okay.
with a single bypass, which they took from my arm. So you can't get a really good pulse in my left arm, which, I got to trick a lot of nurses in school when I was a kid. And then they put a banding on my pulmonary artery because the blood was flowing too fast and my heart was unable, and my lungs were unable to really keep up with the flow, the overflow of it. So that's all they were able to do. And then when I was 12 years old, I had a Fontan, which the best way I can describe it is they basically connected, they kind of severed the pulmonary artery from the heart, and then they connected it to this, the superior vena cava, sorry. And then they put like this baffle or tunnel and blocked off the vena cava from even kind of going through the heart. And the way that the cardiologist just described it to me is essentially there's like a vacuum function going on between my lungs and my heart. So the blood is not actually pumped from my heart to my lungs. It's some weird vacuum seal thing. And then, comes back to the body normal, it's pumped out. So that, and then I've had a pacemaker. They put a pacemaker in the same time, and I've had, I think I'm on my 5th one now.
Okay.
So. Yeah, I get those replaced often.
You basically have one ventricle is
I do.
you are now.
I have a single ventricle, and because of the ventricular septal defect, they actually widened that, so it created a larger single ventricle.
Okay. So tell us a little bit, when were you admitted to the hospital with COVID?
It was March, like 28th or something.
Okay.
I don't remember the exact date. I'd actually have to go back. I got symptoms on a Saturday, got tested on Monday, had the results Tuesday morning, and by the next Sunday, I was telling my husband, I'm not breathing well. You got to take me in. And my oxygen level was dropping. So, of course, he took me to the ER, and that was not pleasant, just being dropped at the door and saying, bye, we'll see you later.
So what were your initial symptoms when you...
I had every single one. The only symptoms I did not have is I was not vomiting. And at the time, I hadn't lost sense of smell yet, but I definitely had no taste. I couldn't taste anything, which was the oddest sensation ever. But I had the shortness of the breath, the coughing, the fever, the aches, the loose bowels, the nausea, all of it.
And then what led you to go to the hospital was just that?
It was the shortness of breath.
The shortness of breath.
That was the really hard thing. I did get a pulse ox and was monitoring my oxygen saturation. And when it dropped into the low 80s, and I could never feel like I was getting a hold of my oxygen and breathing, no relief. I wasn't getting any relief. Okay. Those two things were it. I was like, and my mother is actually who I got COVID from.
Okay.
And she had been admitted 4 days before. And we knew she was there with same reason. She just couldn't catch her breath. So she was admitted with that, and it turned out she had pneumonia, COVID-related pneumonia. So I was like, I need to go in and see if that's what's going on with me. And incidentally, that is what was happening.
Okay.
It had turned into pneumonia.
And then, did you spend any time in the ICU? Did you?
I did. I spent 5 days in the ICU.
Okay.
And it was interesting because I was the only, I asked the nurses when I was in there, was I the only, I wasn't sedated. Mm-hmm. So I was awake and I never had to be intubated.
Okay.
At all, because that was part of the problem. Is the reason they put me in ICU is with the anatomy of my heart, I could not actually be put on a BiPAP or a ventilator.
Right.
Because it would have been way too much. I think the way they described it was too much pressure.
Right.
Since the lungs were struggling so much.
Correct.
So they were worried they would have to put me on ECMO, mm-hmm. and the best way for them to monitor that was to send me to ICU, mm-hmm. so that if that occurred, then they would be right there and I could go right into surgery. And they had it all prepared and were ready. So yeah, I spent 5 days in ICU, terrified that I was going to have to go on ECMO. I was not looking forward to that. That was pretty scary.
I can imagine. I've run an ECMO circuit or two in my nursing career, so I can't, certainly I was of course doing it with kids, but I can't imagine having a conversation like that with an adult that is.
And as sick as I was, it was really hard to retain a lot of what they were saying to me.
Right. So
I'm so glad that, I know immediately when I got into ICU, I was like, I need you to communicate with my husband because mm-hmm. I'm not retaining this, to let him know what was going on. So right. that was very helpful that they had constant communication with my husband, both the cardiologist and the ICU doctor.
Okay.
And I don't think he talked to the pulmonologist, but he definitely was in constant contact with the ICU doctor.
Were you able to have contact with your husband at all?
Yeah. I mean, obviously we texted and
right,
phone calls,
right.
and thank God for Zoom and FaceTime and all that. So I was able to pretty much video chat with my husband every night. I was even able to video chat with some family and friends, and my two stepsons both checked on me constantly. Mm-hmm. I can't imagine going through this pandemic and having to be in a hospital by yourself with absolutely no way to see your family.
Yeah.
And so that was it still was hard, but at least there was something.
For sure. So how long, you said you were in ICU for 5 days?
I was in the hospital a total of 12.
Okay. So what was kind of that turn that you felt got you out of ICU? Like, did you?
Well, the thing that they kept telling me is you need to use the spirometer.
Incentive spirometer.
The breathing thing. Yeah. You need to do that. You need to try and sit up if you can. They encouraged me to sleep on my stomach or lay on my stomach best I could. And I gotta say, that was one of the best things that they ever told me, because that made it so much easier for my lungs to open up and breathe. It was not the most comfortable on my neck, but at that time I was more worried about breathing than I was neck pain. And they they encouraged me, you need to do this breathing treatment every 10 times an hour or every hour. Sit in a chair as much as you can, because the idea is I need to keep those muscles strong, mm-hmm. and of course eat. And even though I was completely nauseous and everything tasted like nothing, I forced myself to eat. I forced myself to use that breathing thing, and because I was terrified of the ECMO, I really was. Mm-hmm. So I just let that push me to do everything they said, and I was uncomfortable, and I didn't like it, and I was exhausted, but I knew that to get better I had to try everything I possibly could, and then let my body do the rest, what they were doing, and then what I could do, my body could do the rest. So, and I think that helped, but the turning point was when they came in and they were able to lower my oxygen. Mm-hmm. when they said, let's try lowering your oxygen, and they did, and they're like, okay. They also did, while I was in ICU, I had the plasma with the antibodies.
Mm-hmm.
I got that the second day I was there.
Yeah.
And I also got the remdesivir.
Okay.
They said, we're throwing the kitchen sink. Like, you're getting it all. And I was like, whatever. And I had a couple of antibiotics for the pneumonia as well.
Right.
To keep, all that down.
Mm-hmm.
So I was like, whatever y'all want to do. And once I was finished with that, then they thought, okay, I think we can move her. Because I responded quite well to all of that.
Do you feel like your experience as a congenital patient, having had surgery at 12, I mean, you probably don't remember the original surgery, but having that surgery at 12, do you think kind of knowing that I'm sure at that point you had to push yourself too, and, really push yourself to get better. Do you feel like maybe that was kind of a little something in your back pocket that kind of pushed you, like, I've done this before, I can do it again?
Right. I mean, like I said, I have to have I get a new pacemaker every 5 years because I'm actually considered pacemaker dependent. Despite having 2 surgeries and pacemakers, at 25, I still went into congestive heart failure. Okay. Now I've been doing so well with that, and I'm very stable. But the pacemakers have to be changed every 5 years. So every 5 years, I get to have a surgery, and then I have to push myself to heal. And incidentally, I had just had it done 2 years ago. Okay. So this was all pushing myself to get healthy and push through it was one thing. And I'm good with that. It was just the unknowing. When I have a pacemaker change, I know what to expect.
Right.
This is what I'm going in with. This is the result. This is how I'm going to feel afterwards. I didn't know what to expect with COVID.
Yeah.
Even though they're like, you're doing really well and you're healthy, there's the possibility that this could turn.
Right.
Which maybe rainbows and unicorns, they want to tell you the truth, and I'm glad they did.
Right. So after you got out of the ICU, how did things kind of go from there?
I kind of plateaued a little bit on the oxygen. I was able to move more because now I was in a room that I could walk around a whole lot more.
Okay.
And I was able to take a shower, which was really nice. But I couldn't believe how short of breath I was just standing up to brush my teeth or to stand in the shower, which they eventually gave me a shower chair. But it was exhausting to care for myself. And so that was why I think I had to stay in an additional 6 days. Because I kind of plateaued on the oxygen, and then eventually we brought it down enough they felt I was fine to go home.
Okay. And
I did go home on oxygen.
Okay. So you don't still require oxygen, correct?
I don't. But I remember thinking while I was home, I was crying all the time. Just like, I'm never going to be me again, and all of this. And it was I'm 43. And unfortunately, metabolism slows down and weight starts up. And so I've started, eating healthier. Right before I got sick, I was really trying to lose a little bit of weight. So I was working out a little more, eating a little healthier, being more, not eating healthier, but being more restrictive about just cheating, I guess is probably better. And then I got this, and it knocked me down to where even coming home and walking around this big oxygen tube on me, trying to make lunch or do the laundry was exhausting. So I'm crying like I'm never going to be able to do what I used to, and very dramatic. And that the reality is that everybody told me that it could take 2 months or so. And I got off the oxygen at home. I was done in about 10 days.
Okay.
I was able to get off of it. I still didn't get back to working out for a while, but it was nice being able to I could breathe. I was getting shorted. Like if I had to go out and wear a face mask, that was hard to breathe through that. And walking around the store, I would get a little bit exhausted, but it just slowly got better. And it was one of those things that I had to push myself. I didn't feel like doing the laundry, but this is part of like moving around, getting my lungs working properly. And so I continued to push myself.
Mm-hmm.
And then when I would get so tired, that was it. Now I rest.
Yeah. Do you have any lasting effects still?
I don't.
That's great.
I don't. I actually was working out a couple of days ago. And, you know, as I start working out, I started light and slow, and I would notice there was a little bit of but this last Sunday, I'm working out, and you start breathing heavy when you work out. That's just normal.
Right.
And it was amazing because I didn't feel restricted in my breathing anymore. And I actually had stood there and had this revelation, and I was like, it's really gone. It's really gone now.
Right.
So
well, that's great.
That was an awesome revelation.
Yeah, for sure. Well, so we have a question for you from somebody in our
Absolutely.
audience. Deborah, from your experience as a single ventricle patient with pretty serious COVID-19, what would you say to other single ventricle patients if you could?
Oh, I've learned a lot over the years about proper nutrition, and that even though I maybe struggle with, I can't do my husband can do like an intense workout and he's not even breathing heavy. I don't have that luxury. But I do think it's very important to continue physical activity, healthy diet. I drink a lot of water. I see I've seen my doctors regularly. I take the medications I'm supposed to when I'm supposed to. And the best thing I can suggest is really take care of your body to the best of your ability. As much as I would love to eat French fries all the time, I don't think that's really good for my heart. So it's just things like that I have to be cognizant of, that, this is the heart I was given.
Right.
And I have to take care of it the best I possibly can.
Yeah.
I hope that answers the question.
Yeah, I think for sure. So are you vaccinated by any chance?
I am not. I know, I was listening to the doctor. I was like, oh, but part of it is I kind of was on that. Do I get vaccinated or not?
Right.
I had a hard time struggling with what was in the news and what everybody was telling me and what everybody wasn't, I got wrapped up into all of it.
Right.
And I'm not a huge, I don't like vaccines. I don't dislike them. It's just one of those things. I kind of weigh it with each thing I need. And I discussed it with my cardiologist, and she was very aware of it. Mm-hmm. And then I got COVID, and my tune changed. So the reason I'm not vaccinated is because it is recommended by the CDC that if you've been given the remdesivir, mm-hmm. That you should wait 90 days before getting vaccinated. Mm-hmm. And both the pulmonologist and my cardiologist specifically said that I needed to wait. Mm-hmm. So I believe July 1st will be 90 days from when I finish the remdesivir.
So you'll have an appointment on July 2nd?
Yes. I probably need to just go ahead and wait. But yes, I have not. And but in the meantime, my husband, my kids, the same thing. We're like, we're on the fence about it.
Right.
And when I got this, everybody's tune sort of changed. Yeah. So my husband has been fully vaccinated. My 14-year-old stepson, or I'm sorry, 14. He's 17. Don't tell him I said that. My 17-year-old stepson has been vaccinated, and my oldest stepson, who is in college, he was on the fence, but he found out that if he got vaccinated, then he didn't have to wear a mask to work anymore. So he got all excited and got vaccinated. Right. But he doesn't live here. Okay. So he is coming home for a visit soon, but they're all three fully vaccinated, and everybody I'm in contact with pretty much is all vaccinated. Yeah. So,
do you feel like you're kind of your experience has impacted other people, like more peripheral to you, you know, not just your immediate family, but maybe your extended family, or even neighbors or friends, anybody that...
Well, you know, we were kind of we were not in the majority of our friends and family that they were more into I'm going to get vaccinated, and we were not. So I don't think so.
Okay.
Because they were already, what I think this experience did was very much impact our household. Mm-hmm. And while I wish I hadn't gone through it this way, this was the path. And it like I said, it very much changed our perspective.
Yeah, for sure. Well, I mean, and it's a shame that had to be the catalyst, but it's a good thing you came out so well on the other side. So
I did.
So that's good. I think you were really lucky.
I'm sorry, what?
I said, I think you were really lucky to.
I was very lucky. And that, I kind of go back to, while I know I have very serious conditions, I very much go back to the fact that I am very good and strict about what I eat, how I eat, how I exercise, what I drink. You know, like I don't do any alcohol. I don't really drink any soda. I don't drink any soda at all. I mean, I stay away from a lot of sugar, carbonations, that whole thing. And then of course all the food stuff, and I try to just keep my immune system boosted in a healthy way. And I think that was such a blessing that helped me get through this. I mean, I remember the day I got admitted and talked to the cardiologist, and they're like, well, what were you doing that day, that the symptoms that came up? That morning I had gone and worked out and ran. Well, let me rephrase that. I do intermittent jogging / walking. But I did all that. And then I came home and cooked lunch and did laundry. It was a normal day, and by 5 o'clock that evening, I was coughing and I felt weak and exhausted. Wow. And the cardiologist was like, you did all of that on the day you got symptoms? And I said, yeah. She says, well, that actually could bode very well for you. She goes, that's promising.
Yeah.
So, yeah, I think it's very important to take care of yourself. It's the best you possibly can.
For sure. Well, is there anything else that you want to share about your experience or share with our congenital population?
I can't think of anything.
No, that's okay. I appreciate you coming on to share everything with us and tell us about your story.
Yeah, it's this very cool experience. I appreciate being asked. This is fun.
Yeah, for sure. It was great having
plus,
you.
I'm hoping I'm going to see my name in lights now.
For sure. People, your husband will be asking for your autograph.
Yeah. He's already my biggest fan, so it's okay.
Oh, okay. Well, that's good. Well, now we are actually going to go to a tech update with Dr. Huie Lin.
Hi, my name is Huie Lin. Here again we are with a tech update on adult congenital heart disease devices here at Houston Methodist at the DEBAKEY Heart and Vascular Center Adult Congenital Heart Disease Program. So today we're going to focus on atrial septal defect occluder devices that we can place transcatheter. For those of you who don't know, this is a technique that's done through the femoral vein, in other words, a small incision made in the vein in the leg. And typically we can use echocardiography, whether that's through a catheter that's also inserted through a vein in the leg, or through transesophageal echo, which is a catheter that's placed in the throat to allow us to visualize the procedure, and it's done in the cardiac catheterization lab. So to review, for those of you who don't know what an atrial septal defect is, we're going to take a look at my simplified diagram of the heart here. And so what we've done here is I've drawn the heart in 4 chambers, and I've labeled the blue blood side of the heart on the right side, and then the red blood side of the heart on the left side. And so, as most of you probably already know, the top chambers are called the atria. This is the right atrium, and this is the left atrium. They're separated from their pumping chambers, the ventricles, by valves. This is the right ventricle and the left ventricle. And the purpose of the right side of the heart is to pump the blue blood to the lungs, and the purpose of the left side of the heart is to take that blue blood from the lungs once it's come back red and pump it to the body. An atrial septal defect occurs when there is a hole that allows blood flow between the left atrium and the right atrium. And so that's exactly what we're talking about, how to treat today. Typically in the past, before transcatheter devices, the only way we could treat this was through surgery, and that required open heart surgery. In fact, in 1953, the very first open heart surgery that was done with cardiopulmonary bypass was in fact an atrial septal defect closure. So let's talk about how we've done atrial septal defect closures in the past. So one of the great advances was this device. This is called the Amplatzer septal occluder. And so as you can see here, what would typically happen is we would advance the catheter up from the femoral vein, and then we'd cross through the atrial septal defect hole, okay? And then we would typically advance the left disc in, and this would sit on the left side of the heart. And then we would advance the right side of the disc in, and this would sit on the right side of the heart. And what I've brought here is I've brought not only this device, but this device, which you can see is much larger. In fact, this is the largest Amplatzer septal occluder. It's a 38 millimeter Amplatzer septal occluder. What 38 millimeter means is that this internal disc that you see here closes a defect up to 38 millimeters. So oftentimes I get asked, gee, can you close a defect that's as big as 20 millimeters? Well, it turns out we can close a defect that's much bigger than that. We can close a defect that's up to 38 millimeters. And in fact, this device is even bigger than that, in that the left disc is approximately 15 to 16 millimeters larger than the middle disc. It's actually about 54 millimeters in diameter. So it's a very, very large device, and it goes in almost identically to the way this device does. And so what you can see here is that there's a very wide range of transcatheter devices that we can use. Now, in the past, then, we started finding that there was a problem in ASD closure, depending on what are called rims. So let's go to a different view of what this looks like in the atrial septal defect. So what we're looking at here is what's called the rims, or the tissue that allows us to engage the device and place it into the atrial septal defect. And so again, typically we would place the left disc on the left side and the right disc on the right side. So here I have demonstrated a nice area where you have rim on this side and rim on this side. Well, I've also drawn here the aorta, which is typically where we're facing an issue. However, what's a deficient rim? You may hear about this every so often. So this is a deficient rim. And specifically what we're looking at here is a deficient aortic rim. As you can see here, there's really minimal tissue on the aortic side, although there's some decent posterior rim, some tissue on the back side. So what that means is we can probably be pretty certain that the device will anchor nicely on the posterior side, but really the only way for this to work on the aortic side would be to have a very large device that would actually hug around the aorta like this. Okay, and so what we found recently is that there is a negative occurrence called erosions. In other words, this is where the device may actually begin to cut into the heart tissue and cause a hole or potentially a catastrophic outcome where there's bleeding internally as a result of this. Now, this is an extremely rare event. In fact, some people speculate that it's less than 1 in 1,000 or even less frequently than that. However, because of this, people have started to shy away from transcatheter closure of atrial septal defects with the thought that perhaps this device may actually cause erosions in this type of anatomy. So today's tech update is to not only tell you about some great advances with this device, which now has this nice blue coating on it, and potentially reduces the amount of nickel that is leached into the bloodstream. But also there's now a new device that's been launched called the Gore ASD occluder. And that's this particular device. So I had just shown you a 38 millimeter device. This is called a 48 millimeter device that can close up to 35 millimeter defects. And what I'm going to do is I'm going to show you how it comes out into the body. So for those of you who actually attended our symposium last year, you may have seen that we actually had a nice little virtual hands-on session where I showed you a similar device to this. And this is pretty similar to what we saw before, which is that once we cross the defect, the left disc goes onto the left side, just like you see here, and it forms up. And then the nice thing about this is because it's slightly softer and covered with Gore-Tex, the thought is that as it hugs the aorta, as it's probably going to have to do in this type of deficient aortic rim, I'm going to go ahead and slowly introduce the right disc, just like this. So when we put this device in, and it potentially hugs the aorta like this, the idea is that this device is less prone to causing erosions. In fact, thus far there have not been any reported erosions, and so this is the update in device technology for closing atrial septal defects using a transcatheter method. In other words, using small incisions through the femoral vein, as opposed to requiring open heart surgery. Now, obviously, there's no such thing as a complication-free technique, and so there are currently still issues with doing transcatheter closures. At the same time, there are also potentially issues with these devices that we know are always going to be a part of any type of medical therapy that we can offer. So, irrespective of the situation, if you think this is something that's interesting or potentially useful for your atrial septal defect, it's an important conversation that you want to have with your doctor. And if your doctor wants to get additional help from experts in this field, it would be a great opportunity to have you referred for a second opinion to either ourselves or other adult congenital heart programs where they're currently doing transcatheter ASD closures. Thanks for joining me today on this tech update, and we'll see you again soon.
Thank you, Dr. Lin, for that tech update on ASD closure devices. I'd also like to thank Deborah for sharing her experience with COVID and her adult congenital heart disease. And finally, I'd like to thank Dr. Peter Hotez. We were so pleased to have him here to lend his expertise on COVID with cardiovascular disease as well as vaccines. I'd like to thank DEBAKEY Education for giving me the opportunity to discuss COVID and congenital heart disease. And thank you to all of you for joining us. We look forward to seeing you on a future episode of CV Live. Have a great evening.